Hi there. Thanks for coming. I've never done this before. I've never read a book while recording myself visually, but here goes. Okay. So this book is Many Lifetimes, and it's by Denys Kelsey and Joan Grant. And they wrote it together. They were a couple. They wrote it together. He was a psychiatrist, and she was a psychic. And I'm going to be reading his chapters. Like they alternated chapters. So I'm going to be reading his chapters. So I'm starting with chapter 2 of this book, and it's called Recognition of a Reality. I should like people to share my belief in reincarnation. I think it would cause them to be much happier, much less frightened, and very much more sane. For a psychiatrist to hold this belief and to have made it the basis of his therapy is still rather unusual. It is not a belief which I have always held, so I will begin by explaining how I was led to it through clinical evidence, which had been accumulating during the 10 years before I learned that somebody called Joan Grant was able to remember many of her earlier lives. So, Joan Grant being his wife, right? Without this work, I would not have been able so rapidly to appreciate the value of what Joan was able to contribute, because, like so many people, I cannot accept a concept unless it satisfies my intellect and relates to my empirical experience. I was precipitated into the practice of psychiatry at the age of 31 without even an hour's warning. In this, I was fortunate. It meant that I approached the subject without any preconceived ideas. For when I was a medical student, psychiatry played only a very small part in the curriculum. I remember being taught that the causes of thyrotoxicosis were, quote, sex, sepsis, and psychic trauma, end quote. And I attributed a series of lecture demonstrations. No, I attended a series of lecture demonstrations, but rather lightheartedly, because questions on psychiatry never occurred in the examinations. And that, to the best of my recollection, was that. But immediately after embarking upon psychiatry, a series of cases came my way, which, step by step, extended the framework of what I believed to be fact until after 4 years, a session with a particular patient forced me to the intellectual certainty that in a human being there is a component which is not physical. To be taught this as a matter of dogma or doctrine is one thing. To be compelled to the same conclusion by one's own experiences is quite another. I did not realize it at the time, but this session was an important landmark on the way to a belief in reincarnation. At least I had got that far in believing in the reality of something which could reincarnate. In 1948, I was working on the medical side of a large military hospital, a post which I owed to the fact that 3 years previously I had passed the postgraduate examination, which is the start of the long road to recognition as a consulting physician or internist. I was still traveling this road when an epidemic of influenza hit the hospital and abruptly changed my course. One of the first casualties was a medical officer in the psychiatric wing, and I was asked temporarily to take over as much of his work as I could. Late that night, I learned that I had an aptitude for inducing hypnosis. I was summoned urgently to the ward to give a sedative injection to a patient who had suddenly become acutely disturbed and violent. By the time I arrived, 3 muscular orderlies had the situation under control and were holding the patient down on his bed. I had a feeling that he was unlikely to resume his violence, so I motioned to the orderlies to leave. But the patient was obviously still very frightened and with no intention beyond trying to calm his fears, I sat down beside him and began to talk to him in what I hoped was a soothing and reassuring voice. I certainly did not realize that I then began to use one of those standard techniques for inducing hypnosis. It had simply occurred to me that if I could get him to fix his attention on something outside himself, he might be less disturbed by his ideas and feelings. So I asked him to fix his gaze on a dim light in the ceiling above his head. For some reason, for the same reason, I coaxed him to concentrate upon his breathing, making it perfectly regular and rhythmical, but a little lower and a little deeper, a little slower and a little deeper than usual. He was still very tense. His fists were tightly clenched and his arms and legs showed a fine tremor. So I drew his attention to each of his limbs in turn, urging him to relax them and to allow them to remain relaxed. These instructions were interspersed with reassurances that he had nothing to fight, nothing to fear. Gradually, he became perceptibly calmer until he was lying completely relaxed. Purely for good measure, I continued talking to him in the same strain, and I recall suggesting to him, quite casually, that he might as well go off to sleep. Excuse me. At this, his eyes rolled up and his eyelids came down in a curiously positive way, and I suddenly realized, to my astonishment, that I must have hypnotized him. The next morning, I described the incident to the psychiatrist in charge of the department, who confirmed that this was certainly what had happened. He was as intrigued as I, and he asked me to repeat the technique on another patient, a man who was suffering from a neurosis as a result of a horrific accident with an automobile. This patient entered hypnosis very quickly and with tremendous release of emotion, relived the circumstances of the accident. The psychiatrist assured me that it would now be a simple matter to clear up the residue of the neurosis. During the next few weeks, I was able to treat several other patients in a similar way. They too relived the relevant episodes with great release of emotions and went on to rapid recovery. I found these experiences in the military hospital so rewarding that I decided henceforth to specialize in psychiatry. Once back in civil life, I took a post in a mental hospital where I remained for the next 6 years. Hypnosis has played such a large part in the experiences I shall shortly describe that I will say something about it. A convenient starting point is the widely accepted concept that there are 3 distinct compartments of mental activity. First, there is the compartment of consciousness, to which I shall usually refer as normal waking consciousness. This contains only the thoughts, the sensations of which we are aware of at any present moment. Next, there is the compartment known as the preconscious. Here is stored every memory, every item of knowledge that can be summoned to consciousness at will. Thirdly, there is the compartment with which a psychiatrist tends to be especially concerned, and which is usually called the unconscious. The contents of this compartment lie behind a barrier, precise nature of which is not known. It may prove to be essentially chemical, electrical, or even purely psychological, but whatever its nature may prove to be, the effect is that the material which lies behind the barrier can be brought across it into normal waking consciousness only with considerable difficulty. Hypnosis is sometimes loosely spoken of as sleep, but this is inaccurate. Indeed, unless a specific suggestion is made to the contrary, a person under hypnosis may be unusually wide awake in the sense that his powers of perception may be abnormally acute. But since such a person is not in a state of normal waking consciousness, perhaps the best description of hypnosis is a state of altered consciousness. An important feature of this state is that it weakens the barrier which confines the contents of the unconscious. This can be of particular value in psychiatry because it may enable the therapist to bring material from the patient's unconscious to the surface much more quickly than would otherwise be possible. I have always considered myself fortunate in that at a very young age, I encountered a patient who illustrated the reality of the unconscious and the power of material held in that compartment in an unforgettable way. The patient was a young woman who was wheeled into the ward in a chair because she had lost the use of her legs. A few days previously, she had awakened in the morning to find that they were completely paralyzed. Examination showed that there was nothing wrong with the nerves or the muscles or the bones, and that this was a paralysis of psychological origin. In conversation, she was clear-headed, calm, and indeed rather cheerful, surprisingly so for someone who, on the face of it, might never be able to use her legs again. We discussed many details of her life, including the fact that since her marriage, she had become very disillusioned about her husband. However, for the previous year, life had not been too bad because he had been abroad on business. Then, almost casually, she mentioned that a few days before the paralysis had occurred, she had received a letter which made her feel obligated to join him. She admitted that she was a bit scared at the prospect, but her principles demanded that nonetheless she should go. She added that her parents would be terribly distressed to learn that all was not well between her husband and herself. Her voice had been level and matter of fact as she was telling me this. There was nothing to suggest a young woman striving to speak coherently while in a state of acute fear, but under hypnosis, when I brought the conversation round to her forthcoming trip, a very different picture emerged. She was not simply a bit scared. She was terrified. And as details of the conditions she expected to find at the end of her journey also emerged, her fear was understandable. She was weeping and trembling, but through her sobs, I heard her exclaim, "I would rather have no legs than have to go." I then brought her back slowly back to normal waking consciousness, insisting, as I did so, that she remember all that she'd been telling me. Now that the full extent of her fear was in consciousness, she was scarcely recognizable as the poised young woman who had been wheeled into the ward. But now her problems were where she could explore them and cut them down to size. We were able to discuss in exactly what respect her parents would be distressed to learn. We were able to discuss in exactly what respect her parents would be distressed to learn the true state of her affairs, and It was not difficult to get her to consider rationally whether it was really necessary to stay with her husband. I was able to remind her that she had earned her living before her marriage and could easily do so again after. By the end of the session, she was very much calmer and already had some power of movement in her legs. During the next few days, we had further talks along similar lines. Suddenly, she declared that she had realized the significance of her paralysis. No, suddenly she declared that she had realized the significance of the paralysis of her legs. It was the only way in which she could avoid joining her husband without feeling that she was betraying what had been her principles. Within days after the session, her legs were functioning perfectly normally. I do not know if the wish to lose the use of her legs had been in her normal waking consciousness, but if it had been and had remained entirely at that level, she would have been able to only fake a paralysis, a performance which she would have found impossible to sustain. But because it was flourishing in her unconscious, I was afforded a vivid demonstration of a principle which is often crucial in psychiatry, that an unconscious wish, if it is sufficiently powerful, may produce an effect that is tantamount to a physical fact, for her legs temporarily were as useless as if they had been amputated. This case was instrumental in focusing my interest on an analytically oriented approach to psychiatry. I use this rather cumbersome phrase because while I acknowledge a debt to psychoanalytic theory, it contains certain cardinal principles which I have never been able to share. Therefore, to describe my work as psychoanalysis would be inaccurate and incidentally unjust, both to the psychoanalyst and to myself. Very briefly, I accepted the concept that the memory of an event, which includes the sensations and emotions associated with it, might be stored in either the preconscious or the unconscious. If it were stored in the preconscious, from which it could readily be summoned to consciousness, then it became part of the total experience upon which the individual could have further decisions. The individual could have further decisions. The majority of our memories fall into this category, but those which are associated with so heavy a charge of unpleasant feelings that they would make life too uncomfortable if they were liable to recur unhidden to our awareness, are neglected, no, are relegated, not neglected, are relegated to the unconscious. Such feelings are not integrated, and instead of contributing to the source upon which we can draw at will, they have the power to force upon us the irrational ideas, feelings, and behavior which comprise the symptoms which we call neurotic. One of the basic principles of therapy is to extricate these feelings and memories from the unconscious so that they can either be integrated or dissipated and lose their power adversely to affect personality. For this person, I found the technique known as hypnotic regression particularly valuable. To get a picture of what happens during a regression under hypnosis, consider two ways in which a person in normal consciousness may speak of an incident which has happened to him. From his position to the present, he may simply be describing something which occurred in the past. In this case, he will use the past tense, saying, I was angry, I was frightened, or I was amused. But he may become so caught up in his story that he slips into the use of the present tense, and his gestures and tone of voice reveal that he is virtually reliving the episode. Either he has been brought up to the present, or, and this may be a more apt explanation, he has temporarily left the present and merged himself with the past for which he is still extant. Regression under hypnosis is an extension of this latter process. The subject may not only relive the incident as it occurred, but because of the breach which hypnosis may make in the barriers surrounding the unconscious, he may recover details of the event and become aware of emotional facets of which, on the original occasion, he was conscious only momentarily. A vivid example of this mechanism was provided by a teenage girl whose relationship with her parents was going through a very difficult phase. I had induced hypnosis for the first time during her therapy, and simply to provide a starting point for the session, I asked her the name of her favorite tune. I don't know any, she replied. It surprised me because one of her mother's complaints was that her daughters spent far too much money on gramophone discs. Gramophone discs. Isn't that lovely? I asked her how old she was. I'm 5, she said, and then she burst into tears. She was already reliving an incident which had occurred when, at the age of 5, she had fallen off a pony, of which she was terrified. Her parents were urging her to remount. She was convinced that they were doing so only in the hope that she would fall off again and be killed. Oh my. The important feature of this regression was that, although in normal consciousness, she would have remembered falling off that pony, which she had distrusted and feared. The conviction that her parents wished her to die caused greater anxiety than she could tolerate, and this aspect of the incident, which was psychologically crucial, she had buried in her subconscious. No, unconscious. Sorry, unconscious. I use the word subconscious all the time. Unconscious. Such a spontaneous regression is rather unusual, for more often a regression is initiated by a specific suggestion from the therapist. I would tend to use this technique when a patient expresses feelings which seem grossly out of proportion to the event that he is describing, for this is nearly always an indication that it has a significance for him in addition to its face value. If the patient agrees that there is a question to be answered, I induce hypnosis and make the suggestion, such as, I'm going to count slowly up to 10. While I'm counting, you will go backwards in time, becoming younger and possibly smaller. And when you reach 10, you will find yourself back in some situation which will help you to understand why the episode that you've been describing meant so much to you. On other occasions, having induced hypnosis, I would start the session by using one of the so-called projection techniques. I would ask the patient to visualize a blank cinema screen and then tell him that at the count of 10, a picture would appear on it, which would take over as our starting point. When he had described the picture, I would use regression to help us understand its relevance. An apparently trivial episode may prove exceedingly useful. A girl of 19 found herself back at the age of 10 playing ping pong with her brother. I asked her, "The score?" Without hesitation, she testified. No, she replied, 19-17. She was looking worried. So I asked her, what was the matter? And she answered, "I think I'm going to win. And he always gets so cross when I do." Suddenly, she brightened up. "Thank goodness, the dog has just come in, and we must stop playing because the cat is here already, and they always fight." This small scene led us to her intense rivalry between her husband and herself, which was an important factor in her illness. The task of a therapist is to use his understanding of the particular case, his knowledge of psychological mechanisms, and his intuition to judge whether an incident to which the patient has regressed is relevant or simply a cover story. In any event, the patient seldom reaches the crucial situation at the first attempt, and it is usually necessary, following approximately the same procedure, to induce him to go further back still. I had become accustomed to seeing adult patients reliving events which had occurred when they were only 3 or 4 years old, when a patient regressed to the age of 2. She found herself being taken into her mother's bedroom to be introduced to a newborn brother. Fury was mounting within her at the sight of a baby nestling happily in the arms of her mother, when the nanny noticed a rash on her neck. The nanny suspected measles and whisked her back to the nursery. Measles it proved to be, and in a sad little voice, the patient declared, "I'm hot and sticky and red all over." She interpreted her symptoms as the outward signs of the hostility she felt towards the new baby, and believed that she was being isolated as a punishment. Shortly thereafter, the same patient provided me with an experience which transcended anything I had previously encountered. The session had begun in a perfectly ordinary way. I had induced hypnosis, asked her to see a cinema screen, and on the screen see a number, and the number she saw was 5. I asked her if the number 5 meant anything to her. She thought for a moment, and then she replied, "Only that I have 5 fingers." "Anything special about your fingers?" "Only that I bite my nails." Nail biting sometimes has a psychological significance, and I felt that this might be a clue worth following up. So I told her that at the count of 20, she would be back in a situation which would throw light on her nail biting. She found herself sitting in her pram, aged 9 months, wearing only a hat and biting her thumb. This regression was already to an earlier age than had been reached by any of my other patients. Yet I felt sure that there was still more to be uncovered. So I told her that she could go back further to a time when she was biting something else. Even as I was counting, she was becoming very red in the face, pummeling the wall with her hands and making violent sucking motions with her mouth. I asked her to tell me what was happening. "My mother is holding me to her breast to feed me, but there's no milk coming out." After some moments, she gave a start of surprise. And again, I asked her what was happening. "She has put me over to the other side." The sucking and the pummeling on the wall were resumed, and then there was another start of surprise. followed this time by a wail and tears. She's put me down and gone away. A few days later, I had an opportunity of discussing this session with the patient's mother. She declared at once that the incident could very well have happened. She had been unable to produce any milk, and in the hope of stimulating a supply, had put the child to the breast at each feed before giving her a bottle. But on the advice of her doctor, she had discontinued this practice after 3 weeks. She was quite sure that she had never spoken of this to her daughter. Indeed, the whole matter had seemed so trivial that she doubted if she had mentioned it to anyone. She was entirely justified in considering it trivial. Innumerable infants must have had similar experiences without any ill effects whatsoever. It had become significant only because of the way in which this patient had reacted to it. This reaction was, in fact, quite complex. During the next 2 or 3 sessions, I regressed her repeatedly to the incident, and it gradually became clear that although her mother had put her down and gone away, only to fetch her bottle, the child had seen this in a completely different light. She had believed that her mother was deliberately withholding the milk, and that the anger she had felt on this account had been caused by her mother, no, had caused her mother to vanish. Understandably, she developed a very exaggerated idea of the power of her anger. And this was a basic factor in her illness. As she gained this insight, her illness rapidly receded, and as she has not had a relapse in more than 15 years to a condition with which occasional intermissions had crippled her life for the previous 10 years. It seems justifiable to say that she was cured. It is pertinent under the circumstances to add that the hospital where she had previously been treated, she had been advised that her only hope of relief lay in the operation of leucotomy, Leucotomy. Not too sure what that is. I had never felt any doubt that this patient's regression to the age of 3 weeks had been genuine, and taking the other factors also into account, seemed to me that I had irrefutable evidence, not merely that the mind was capable at a very early age of registering and recording events, but that it was capable also of a complex reaction which might be the source of a neurosis in the future. To put the point the other way around, it seemed there was no doubt that a neurosis might result from the way in which an individual had reacted to an event when only 3 weeks old, and that through hypnotic regression, it was possible to bring this event back to normal waking consciousness. With this in mind, during the next few months, I caused a number of patients to regress to this early age, and it became abundantly clear that their ability to do so was not even unusual. The patient who took me the next step forward, perhaps I should say backward, was a woman of 40. She had been under treatment for several weeks when a session occurred in which she relived the experience of her birth. I had started the session by inducing hypnosis and asking her to see a picture. She saw the sand dunes as they appeared from her bedroom window at home, and she uttered the words, "Sand dunes." A train of thought flashed through her mind. Sand dunes, shifting sand, here today and gone tomorrow. excellent symbol of insecurity worth exploring. So I said to her, at the count of 10, you will be back in a situation which has for you the same emotional significance as these sand dunes. I had no idea what her response might be, but when on reaching 10, I asked her where she was. She replied, I am 13 at school. All the other girls are wearing summer frocks, but I am still wearing a winter one. I feel very embarrassed and out of place. I asked her to go back further. I am 5. I'm at a party and I want to go to the lavatory, but all the grown-ups are strangers and there's no one I can ask. I feel hot and uncomfortable. Still further back, she finds herself in the basket of her brother's bicycle. He is taking her for a ride and swerving too fast around a corner. She feels unsafe. At 6 months old, she is in her pram, being taken for her first outing in the dark. The way lies through an avenue of pine trees, which are swaying and creaking in the wind. She fears that one of the trees will fall on her, and she's very frightened. At the age of 3 weeks, she finds herself in her mother's bed. At this point came one of the small but intensely personal touches, which, as one is observing a regression, gives such a strong sense of validity. She is in her mother's bed because she has an earache. My mother is putting her nipple in my ear to soothe it. I asked her to go even further back to a time when she felt the same tone of emotion. And she said, I'm very tiny. I seem to be lying on something very soft and white. I am very comfortable, but somehow it's not right. I used to be part of a oneness, and now I am separated. At this, I told her that at 10 she would find herself again part of the oneness. As I reached 10, she said, quietly and positively, this, and when he says at 10, he means like counting to 10. So not the age of 10, counting to 10. As I reached 10, she said, quietly and positively, this is the womb. She went on, there's something beating in me and through me, my mother's heart. I can't see, and it feels as if I have got no mouth. I asked her in what position she found herself. She replied, curled up, and immediately assumed the posture of a fetus. As she seemed perfectly comfortable, I left a nurse with her and went to fetch a medical superintendent to see this interesting phenomenon. While he watched, I told her that at the count of 10, she would start to leave this place. At 10, she arched her back. She put one hand on her head, and an expression of severe suffering appeared on her features. She was portraying exactly what one can imagine a baby feels when the first contraction of the uterus clamps down upon it. In a moment or two, this attitude was relaxed, only to be repeated some minutes later. Her assumption of this attitude intrigued me. From time to time, this patient suffered from a pain in her hip, which was accompanied by a pain in her head, and had been subject to it for as long as she could remember. She had consulted numerous doctors, but none of them had been able to either account for or relieve it. If an attack of the pain came while she was standing up, it would induce a particular gesture. She would put one hand on her head and the other on her hip, and arch her back in a peculiar way. At the same time, her face always assumed that same expression and acute distress. As nearly as her position curled up on the bed would permit, this was the posture and expression which she was now intermittently displaying. Fearing that the stage might be as protracted as during the original confinement, I intervened and I told her that she could move forward to actually leaving the womb. She began to moan from the pain in her head. And then, just as one felt that her head must soon emerge, she suddenly gasped, "I can't breathe," and she appeared to be fighting desperately for air. There came a short period of gasping and gulping, interspersed with cries that she could smell blood. It was exceedingly distressing to watch. Then suddenly she gave a great sigh of relief. "Ah, that's better," and began to fall asleep. In due course, I told her that I would count slowly to 20, and that as I was counting, she would grow up to the present day. And as I reached 5, she spontaneously uncoiled herself. I brought her out of hypnosis very gradually. Even so, she awoke with a blinding headache, which was only relieved by re-inducing the state and suggesting very strongly that she could awaken without it, and then awakening her still more slowly still. In this particular instance, anybody who wished to do so could find theoretical grounds for protesting that there are other possible interpretations of this scene than a regression to the state of being unborn in the event of birth. For one thing, a close relative of the patient was a professional midwife. However, there is nothing to be gained by arguing the matter at this point. So I will merely reiterate my own belief that the regression was genuine. On the basis of this belief, during the next 2 years, I helped many patients to relieve the experience of their births. I became familiar with witnessing revivifications of such details as being born head first or tail first, of the head being being gripped by forceps, of the patient being almost strangled by the cord being wound tightly around the neck. I think an unprejudiced observer would have considerable difficulty in explaining each one of these as either an act deliberately staged for my benefit or the reenactment at my suggestion, not of a genuine experience of which the patient's mind had retained a record, but of a fantasy based upon information they had acquired. I also gained reason to believe that from at least as early as the 5th month of intrauterine life, the unborn baby is aware of itself as an individual. It is aware of its sex, of its position, of the length of time it has been in the womb, and of the relationship of its limbs to one another. One patient who has had a most difficult birth regressed to a period which he stated positively was the 5th month of an intrauterine life. He was aware that the cord had become wound around his neck, and also that his right arm had been trapped beneath his right leg. I have no obstetrical records to confirm this, but it would account most adequately for the difficulty experienced in delivering him. I remain puzzled by the fact that patients often dated memorable intrauterine events so positively. until 10 years later, Joan offered what I think is the correct explanation. A mother is usually very conscious of the precise stage of her pregnancy, and the fetus picks this up by telepathy. I'm going to pause here and come back